This is the last lecture in the last session, in the last day in this fruitful Congress. I'll talk about complications after instability surgery. Firstly, I'd like to express my deepest gratitude and thanks to all EGA boards, especially Professor Dr. Adel Hamid, for giving me this opportunity to become with us today. Firstly, I'd like to ask how many of you faced complications after instability surgery procedure? Please raise your hand. I think all of us, it's a common instability surgery procedures for shoulder surgeon is a daily practice, and all of us well faced a case of complication after instability surgery. Although instability repair procedures are secure and safe, but several complications have been reported in the literature. The surgeon must be aware of these complications to recognize them and provide optimal and timely management to improve outcome and patient satisfaction. Complications may be related to soft tissue procedures or bony procedures. I'll talk about complications of tissue procedures firstly. These complications may be preoperative complications, mainly concerned with the indications of the choice of the type of operation, including type of instability, type of soft tissue lesion, bone loss, instability severity index score, or intraoperative or perioperative complications during surgery, including anesthetic complications, positioning of the patient, surgical technique, and anchor composition and design. And lastly, post-operative complications, which may be immediate, intermediate, or late post-operative complications. As regarding preoperative complications, which mean indication for surgery, you must keep in your mind the type of instability. We only choose soft tissue procedures for polar type 1, according to Stanmore classification, which is traumatic and there is a structural deficiency in the glenohumeral joint. And avoid any surgery in case of hyperlaxity or hypermobile joint. Always keep in your mind also the bone loss and the glenoid tract concept. You must know the on-track and off-track lesion and avoid surgery also in cases of off-track lesion. Also, ISIS score is very important. As Boalok said, patient with an ISIS score more than 4 had a 70% chance of failure, while patients with less than 4 score has less incidence of post-operative complications. Intraoperative complications during surgery may be anesthetic-related complications, as nerve block complications, pneumothorax, and nerve lesion. And also, if there is a high blood pressure, this may lead to intraoperative bleeding and disturbing the field of vision. Also, the low blood pressure can lead to cerebral hypoperfusion. Positioning of the patient. In the lateral decubitus position, you must keep in your mind there is a high risk for nerve traction injury and also the stress ulcers over the pressure areas on the contralateral shoulder or the common peroneal nerve on the contralateral knee. While in the bridge chair position, there is a risk for cerebral hypoperfusion and cervical injury due to excessive deviation of the head and the neck during the procedure. One of the most common complications that the surgeon may face it during surgery is an unexpected situation. Either the arthroscopic finding is too good or there is no capsulolibral soft tissue to be fixed. So you must take a written consent from the patient before surgery to be able to shift to another procedure, which may be open procedure to treat the condition of the patient. There is a lot of instrument-related complications, like in this patient with the broken suture basal instrument in the glenohumeral joint. And also there is a lot of complications related to the implant itself, including loosening, migration, breakage, and the incidence is about 0.3%. During putting the inferior anchor, you must keep in your mind the most inferior anchor may penetrate the inferior glenoid and may injure the axillary nerve, especially if you put the inferior anchor through the anteroinferior portal, like in this case. Metal anchors may lead to loosening and migration, chondral damage, and limit further investigation by MRI. Bioabsorbable anchors, which are made of polylactic acid, may lead to inflammatory reaction, osteolysis, chondrolysis. And after the development of biocomposite anchors, the rate of osteolysis and synovitis has been lowered. All soft tissue anchors, the recent era of all soft tissue anchors, decrease removal of bone and decrease glenoid volume occupied, but can lead to tunnel increase about after 12 months after shoulder labral surgery with low rate of cyst formation. Osteolysis and chondral lesion may occur with metal anchor or polylactic acid anchors with loose chondral flap in the anteroinferior glenoid, and we can see the dye is present between the chondral flap and the glenoid, which means there is an unstable chondral flap. Also, blind knot tying without visualization may result in a glenohumeral suture impingement, which can lead to synovitis and pain, post-operative pain for the patient. Post-operative complications may be immediate post-operative or mid-term or long-term post-operative complication. Post-operative complication, immediate post-operative complication include nerve injury. The rate of nerve injury in Bankert repair is about 0.3%. Could be injured by anchor, suture, or repairing capsular lesion. As in this case, this is a case of Bankert repair. The patient developed post-operative axillary nerve injury, and after 6 months of no improvement with physiotherapy, exploration was done for the axillary nerve, which showed the axillary nerve is strangled by the sutures in the axillary, in the anteroinferior area of the glenohumeral joint, and the repair of the axillary nerve was done. Infection in arthroscopic Bankert repair, fortunately, is rare. If infection can't be controlled, arthroscopic synovectomy and the drainage is recommended. Removal of anchors is not recommended unless peri-anchor infection is apparent. Mid-term complications include stiffness, persisting pain, and chondrolysis. Stiffness, most patients respond to conservative pathway, including injection and physiotherapy, and arthroscopic intervention should be considered after unsuccessful conservative treatment over 6 months performing arthroscopic capsular release. And I think this is the answer for the question by Dr. Muhammad Abu Noor in the previous session. Persisting pain, the overall complication rate in patients undergoing labral repair was nearly 6%, and one of the most common complications was persisting pain. Chondrolysis, which is characterized by rapid destruction of articular cartilage, and the radiology show narrow joint space, loss of articular cartilage in the MRI, characterized by progressive, severe, and refractory loss of comfort and function. The cause may be due to extensive use of thermal devices or intra-articular local anesthesia. So avoid the excessive use of thermal devices and avoid intra-articular injection of local anesthesia. Long-term post-operative complications, including osteoarthritis and redislocation. Previously published studies following Bankert repair reported post-operative rates of osteoarthritis to be as high as 26%. Osteoarthritis, these are the predisposing factors to develop osteoarthritis after instability surgery procedure. When we do surgery in older age at time of first dislocation at surgery, increased length of time from first episode to surgery, increased number of pre-operative dislocation, more degenerated labrum at surgery. This is a case of post-operative osteoarthritis after arthroscopic Bankert repair. As regarding redislocation is the main complication after anterior shoulder stabilization. Recent studies have shown a recurrence rate ranging between 5 to 19% after arthroscopic Bankert repair. This recent systematic review and meta-analysis discussing the risk factors for recurrence after Bankert repair, and they concluded that patients younger than 20 years of age, Hill-Sachs lesion, glenoid bone loss, shoulder hyperlaxity, and an off-track lesion appear to be significant predictors of recurrent instability. Complications of bony procedure discussed yesterday by Professor Sharif Bishai in shoulder instability session, but we can summarize them in the following: neurovascular complications, coracoid fracture, graft avulsion, fibrous non-union, graft resorption, graft malpositioning, screw impingement, stiffness, loss of external rotation, recurrence, and osteoarthritis. These are examples of some complications after bony Bankert procedure, as coracoid graft avulsion or extensive osteoarthritis after Bankert repair. To summarize and take home message: recurring instability, recurring dislocation, external rotation limitation, and arthritis are major surgical complications. A better understanding of possible intraoperative and postoperative complications, including their pathology and the treatment, is essential for satisfactory outcomes. Thank you.